Hello everyone, welcome to Unacademy. Let's crack NEET. I am Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience in undergraduate and graduate medicine, and I have done my MBBS and Rajiv Gandhi University of Health Sciences. Okay, so today we are going to have a discussion on hemophilia and discussing von Willebrand disease. Okay, so this we are basically going to discuss the clinical features, the various investigations, management of each symptom. So that is how we are going to discuss. Fine. So before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and there are a lot of benefits you can avail from this platform. Firstly, the daily life class. Okay, so there are various educators in this platform who have regular classes and all day. Okay, so you can attend your favorite educator class, engage in discussion, ask your doubts, and all these doubts are answered in live chat. Next, coming to the structured course. So whenever you're preparing for your entrance, you have a structured approach, plan really well. So by the time you give your exam, you would have revised well, right? So here in Unacademy, all our courses are structured in line with your exam syllabus, and this is going to be a huge for your preparation. Next, coming to the live tests and quizzes. So again, whenever you're preparing for your entrance exam, you evaluate yourself. You know what are your weak areas, what are your strong areas, and that is possible only if you attend as many tests and quizzes as possible. Here in Unacademy, there are regular tests and quizzes happening, and this will help you to evaluate yourself better. And this also will do a detailed analysis of your performance and will help you to concentrate on topics you are at strong at. Next, coming to the unlimited access. So once you subscribe to the subscription, you get unlimited access to all the classes which are exclusive to the subscription platform. So if you miss a live class also, you can still go back and watch the recorded classes again and again, all this in the comfort of your home, comfort of your own device. So I highly recommend this platform, and using this platform for part of your long way. Okay, so these are the top educators in the platform, and they have regular classes, and you can attend their classes as well. Coming to the courses offered, so all the 19 subjects which are required for your NEET preparation are taught in this platform. And if you go and see the Unacademy app, there are various courses like the batch course, the foundation course, there are crash courses, various subjects. So basically, these are all brief classes of all, like it could be a compact class of various subjects. Go and attend classes. So you subscribe to the subscription, get access to all these courses. Okay. Next, this is a NEET PG subscription package. So as you can see, the NEET PG subscription package varies from 1 month to 2 years. So the one I would suggest the 1 year or the 2 year subscription, especially for the students who are in their third year, in their final year, or in their internship, where not come and watch these classes the full day, right? So you have your hospital work, your clinic, and clinic classes and all that. So for them, the 1 year and the 2 year subscription very, very economical. And the students who are giving their NEET PG 2021, for them the 6 month subscription suffice. Okay, the 6 month subscription will cost you 20,000, and using my code Shilpa 10, you get a 10% discount, and it will come up to 18,000. The 1 year subscription costs you 25,000. Using my code Shilpa 10, you get a 10% discount, and it will come up to 22,500. While the 2 year subscription costs you 30,000, and my code Shilpa 10% discount, it will come up to 27. So I highly recommend this platform. Prices are very reasonable. There are various educators. You can attend any of your favorite educator class and can enrich your knowledge, and also it can help you to crack your NEET. Okay, so now we'll start today's topic. Okay, so the first topic is hemophilia. Okay, so what is hemophilia? So basically, the lack of either factor 8 or factor 9 leads to hemophilia, right? So this is the most common severe bleeding disorder. Okay, this is the most common severe bleeding disorder. So there is hemophilia A and there is hemophilia B. Deficiency of factor 8 and there is factor 9. Okay, so this leads to hemophilia. Fine. So now coming to the clinical manifestation. So how how do these children present? How will a newborn present? So first thing you should know is this factor 8 and the factor 9 doesn't transfer through the placenta. Okay, and this may even occur at birth. Okay, around 2% of the newborns might have intracranial hemorrhage, only 2%. Okay, and some children might have severe bleeding when they have a circumcision done, to severe bleed following circumcision. So especially very important thing is there should be a family history. So most of the time there are so many de novo mutations also happening. Okay, so there are a lot of de novo mutations happening. Okay, so in such cases there won't be a positive family history. So when there is de novo mutations happening, it is very difficult to diagnose. Okay, and in such conditions they will come with bleed, and only then the diagnosis happens. So many times when there is de novo mutations, the diagnosis is missed. When there is a family history, you will be sure, okay, this child can have. So you would have examined and evaluated this child well. But if it is a de novo mutation, it is difficult to diagnose. Okay, so that is one thing. So how do these children present? In children, when is the first presentation? So one, I said there could be intracranial hemorrhage in 2% of the children. So presentation. So when will you see that these can present? So especially when these children try to walk with support, when they start moving, okay, there could be of easy bruising. There could be easy bruising. There could be intramuscular hematomas. There could be also hemarthrosis. So what is hemarthrosis? There is bleed and swelling at the joints. Okay, so hemarthrosis. So basically in the yesterday's class I had discussed what are the sites of bleed in a coagulation disorder. So the site of bleed is in a deeper area, so including soft tissue or the muscle or the joint spaces. So that is the most common area of bleed in a child with hemophilia. So when they have easy, there is intramuscular hematomas, hemarthrosis, that should give you a clue. So especially when the child starts to move around move around with holding support, that time the presentation happens. Okay, so now when they come with hemarthrosis, so if it is a first episode of hemarthrosis, what happens? So it is very, yes, very good, Aparna. So in hemarthrosis, first time when you come with the child comes with hemarthrosis, first of all, children won't be able to tell. Okay, so until they have a huge swelling, the diagnosis won't happen. But in older, so this is early onset. So in early onset, until a swelling happens, the diagnosis of hemophilia might not happen. But in older children, they know when the bleeding happens. So when there is a warm tingling sensation at the joints. Okay, so in hemarthrosis in older children, there is a warm tingling sensation. So even before the pediatrician or a physician detects it, the child already will tell, I have this kind of a sensation. So that will help you in the diagnosis. Okay, so hemarthrosis in early onset in a small child, they will not be able to express the pain or the tingling sensation until they have the swelling. They might not be diagnosed at all. Okay, so this is one thing. So tell me, which is the first joint, common first joint to lead to hemarthrosis? So any idea what is the first joint which can go for hemarthrosis? Just, yeah. So tell me, which is the first joint which can go for hemarthrosis? I'm not talking about the target joint. So target joint is different. I'm asking which joint in the body, the most common joint, first joint to go for hemarthrosis. Sumitra, right? It is the ankle. It is the ankle joint. Okay, later the first joint to go for hemarthrosis is the ankle joint. Later it can involve the knee, the elbow. Fine. Okay, so now the next point is, what is a target joint? What is a target joint? Okay, so do you all know now? The first joint to have hemarthrosis is the ankle joint. Eventually, it can go to involve the knee and the elbow. But the common first joint to involve is the ankle joint. Now, what is the target joint? What is a target joint? The target joint is when there is recurrent hemarthrosis in the same joint happening. That is called as the target joint. Recurrent hemarthrosis in the same joint. So that joint becomes the target joint. So that you have to keep in mind. Yes, very good, Sumitra. Repeated joint bleeding in the same joint is the target joint. Okay, so that you have to know. So right now, so generally when this recurrent bleed happens, it could be a spontaneous bleed. Okay, there is not necessarily a trauma should be there, nothing, there is a spontaneous bleed. So basically when the factor levels go to so low, there can be spontaneous bleed. So when there is a recurrent hemarthrosis happening, that the chances of going for spontaneous bleed becomes high. Fine, so now we were talking about hemarthrosis. So next comes the muscle bleed. So in muscle bleed, what happens is they will have pain, they'll have swelling. So the children will generally tell, and it is easier to diagnose. But the main importance is the iliopsoas. The iliopsoas muscle. So if there is a bleed in the iliopsoas muscle, what happens is there is so much bleed happening. It is very difficult to be identified. Okay, and the bleed can be so much that the child can go into hypovolemic shock. Hypovolemic shock. Okay, so this is very important. So how will the hips be in a child who has a bleed in the iliopsoas muscle? How will the hips be? How will the hips be? What is the position of the hips? So whenever there is a iliopsoas muscle bleed, you have to be very careful, because the amount of bleed will be very severe, and sometimes if it's so severe, they might present with a hypovolemic shock. So tell me, what is the position of the hip? Okay, so hip in these children will be flexed and internally rotated. Internally rotated. This is because of the irritation. Yes, flexed. Yes, right, Surya. It is flexed and internally rotated, and this is basically due to the irritation to the iliopsoas muscle. Okay. Yes. Yes. Tendon. Yeah, but so this will be rotated. So now, how do you diagnose? So when you try to extend, you're not able to extending the hip, not possible, and the child there will be severe pain. So extending the hip is not good, but you can't just confirm the diagnosis with this. You have to get an ultrasound. You have to get an ultrasound to confirm the bleed. Okay, you have to get an ultrasound to confirm the bleed. So this is very important, or CT you have to get. Okay, so there are various other life threatening bleed. So there are various other life-threatening bleeds. So what are the various life-threatening patients with hemophilia? There could be a severe intracranial bleed. There can be an intracranial bleed, bleed to the central nervous system, bleed to the various important vital organs, right? So in such patients, you have to soon, fast treat the patient with the coagulation factor, okay, and then get a imaging. So very important. So remember, in life threatening conditions, treat first and image later. Okay, image later, because otherwise the bleeding can be so much, it can be life threatening, and you might lose the child. So very important, treat the child first and image later. So this is very important. The factor replacement should be done immediately. Okay, so this is very important. Okay, so another thing you should know is in patients who have, I just read there's no space, so let me, okay, I keep my phone here. Yeah. So in yeah, so in patients, oh my god. So in patients who have mild hemophilia, so over here the bleed is not very often, so they don't present with severe bleeds. Okay, so especially when they've gone through a dental surgery, dental procedure, there will be bleed. Okay, the dental procedure, there'll be bleed. Then if they've undergone a surgery, there'll be a bleed. Okay, but it will be controlled. So in mild hemophilia, hemarthrosis and all is little rarer. So generally post intervention or a post procedure, there will be bleed, so that you have to keep in mind. Okay, fine. So this is a picture of hemarthrosis. So you can see the swelling, the huge swelling. So based on this, following this swelling, they won't be able to walk. I mean, they'll be having a limping gait. Okay, so this is the picture of hemarthrosis. Okay, so this you have to know. Fine. So what are the laboratory findings? So yesterday in the class of approach to bleeding disorders, I had told one important thing. So tell me, out of the PT and the APTT, which will be elevated? So now tell me laboratory findings. So in hemophilia, out of PT and APTT, which will be elevated? So yesterday we had a small discussion. I've told you that is very important as well. So tell me, out of PT and APTT, which is elevated? Yes, the APTT is elevated. Very good, Aparna. So when see, always when a child with bleeding comes, you will first get a platelet count, right? Both yes, Sumitra and Aparna, right? APTT elevated and PT will be normal. Okay, so when a child with bleeding comes, first you get a so you get a platelet count. If the platelet is decreased, you have the various causes. If the platelet is normal, then you have to get a PT and APTT. So based on the two, you have to, like, in APTT and PT, both are abnormal in kind of liver disease of the patient is an oral coagulant, oral anticoagulant. But APTT is elevated, especially in hemophilia and in von Willebrand disease. And PT is raised in factor 7 deficiency. So you should remember that. So APTT or PTT is elevated. Very good. Next is the factor assay. Okay, you should do the specific assay for the factors. Specific assay of the factors. That is factor 8 and factor 9. So this will confirm the diagnosis. Yeah, so you do platelet count and that and all only as a thing. Yes, very good. All that is normal. So APTT is elevated. That is the main thing for hemophilia, and you have to get a specific assay. Once there is an APTT elevation there, you have to get a assay of the factors, especially the factor 8 and factor 9 to confirm the diagnosis. Okay. So now tell me, what is the inheritance? What is the inheritance? What is the inheritance? Yeah, so now tell me, what is the inheritance? Yes, upper correct. CT is not normal. CT won't be normal. Correct. Sumita, right. That is a very good. Okay. Clotting time won't be normal. But that is not done. So forget about the clotting and the bleeding time. It is non-specific. Now we are not doing it. Okay. It is X-linked. It is X-linked recessive. Very good. So the inheritance is X-linked recessive, and always a 3-generation pedigree is needed. Pedigree is needed. Okay, so generally the grandfather will be affected, and then that is the carrier state is transferred to the daughters, and then the grandson. If the grandson is born, then there is a 3-generation pedigree is very important. So this is the inheritance. Okay, so how have we divided the hemophilia? So hemophilia is divided into mild, moderate, and severe. Okay, so we have yeah, don't confuse with the clotting time. Leave it. Don't confuse it with the clotting time. That is not a very important test. Very important test is APT. Okay, don't use that. Now fine. Now tell me, how will you all tell hemophilia is mild, moderate, and severe? So now based on the activity of the factor. Okay, so if the factor involved, the activity of the factor is less than one. Sorry. So if the activity of the factor is less than 1%, then it is severe. Okay. While the activity of the factor is between 1 to 5%, it is moderate hemophilia. Okay. While if the activity of the factor is more than 5%, it is called mild. It is called mild. This thing, hemophilia. Okay, so remember, less than 1, 1 to 5, and more than 5. But normal, what is the hemostatic level of hemostatic level? So to maintain hemostasis in the body, what is the hemostatic level of the factors, of factor 8? So it should be more than 30 to 40%. To maintain hemostasis in the body, there should be at least 30 to 40% of activity of factor 8. While factor 9, it should be between at least 25 to 30%. So the activity of these two factors should be more than 30 to 40% for factor 8, and more than 25 to 30% to maintain hemostasis. So this is the basic level. This much should be there to maintain hemostasis. Okay, yes, so this you should know. For factor 8 is 30 to 40. So this is basic, 30 to 40, and it is 25 to 30. So remember this much. Okay, yeah. So now coming to the treatment. So what is the treatment? So whenever, so basically treatment is what? Replacement of the factor, right? So you have to get a formula, how much you transfer. So now there is the dose of the recombinant factor 8. That is equal to percentage of the desired how much activity you want, percentage of desired activity of the factor into body weight into 0.5. So for factor 9, it is percentage of desired plasma factor 9 into body weight into 1.4. Okay, so this percentage of desired activity changes based on the type of bleed. Okay, so if there is a mild bleed, then you can take it as 35 to 50%, 35 to 50%. But if it's a life-threatening bleed, okay, if it is a life-threatening bleed, like a bleed into the central nervous system, or a severe bleed, the child has come with a hypovolemic shock, that time you have to take this desired activity as 100%. Okay, so that much replacement factor should be given. So that should be 100%. This is very important. Okay, so if it is a mild to moderate bleed, you can make the percentage of desired activity of the factor as 35 to 50%. But if it is a very severe bleed, then you have to give for 100%. Fine. So this is very important. And another very important thing is the prophylaxis. So I'll talk about prophylaxis next. So what is one drug which is used in mild hemophilia? So tell me a drug which is used in mild hemophilia. Do you all know? What is the drug which has been used? In mild hemophilia, there's a drug which has been used. What drug is it? There's a drug. So the drug can be given intranasally. Any idea? Yes, very good. So that drug is desmopressin. Desmopressin. So desmopressin is given intranasally. So this is a concentrated form of desmopressin. Desmopressin is given. So what does this do? So in mild hemophilia, this desmopressin will increase the endogenous production of the factor 8. So it will have the endogenous production of factor 8. Okay, so this is a drug. I don't know what no tranexamic acetone is used in von Willebrand. So we will not talk about that. So right now we are talking about desmopressin. So desmopressin will cause an endogenous production of factor 8. So that is why it is used in mild hemophilia and not in other conditions. And another thing I forgot to tell is out of factor 8 and factor 9, 85% of the cases are factor 8 deficiency of factor 8, while 15% is due to the deficiency of factor 9. Okay, so this you should remember. So in mild hemophilia, first very important thing is we have to transfer, give the recombinant factor or the replacement factor should be given. Next, another very important the drug is which is desmopressin. It is used intranasally, especially in mild hemophilia, which causes the endogenous production of factor 8. Okay, so there is prophylaxis. So in whom do you give prophylaxis? So in whom do you give prophylaxis? So in patients who come with recurrent hemarthrosis, you give prophylaxis of the factor. Okay, the prophylaxis, the replacement factor prophylaxis is given in order to prevent in order to prevent spontaneous bleeding. Okay, in order to prevent spontaneous bleeding, replacement factor prophylaxis is given. So this you have to know. Okay, so when this prophylaxis has to be given, there is you might have to give it in once a week or once in 2-3 days. So based on the baseline factor 8 levels. Okay, this is a very expensive thing to do prophylaxis, because you will have to give almost every week you might have to give, or twice a week also, to give prophylaxis. So the basic reason to be given is to prevent spontaneous bleeding. Okay, so that is one thing. So what are the supportive care you give? What is the supportive care you give? So first of all, remember these patients can have trauma-related bruises, right? So when traveling in the car, they have to wear a seat belt. Okay, seat belt is very, very important. Then the parent should be given the guidance about how the disease progresses, so that they don't become over cautious. Like the child can live, but you should be telling if this happens, the child can have. You should educate the parents really well. Thirdly, you have to see that the child is not involved in a very aggressive sport, okay, where you hit 10 dollars. So the child should be avoided in some certain aggressive sport. So that is very important. Avoidance from aggressive sports, parent counseling, like seat belts. So these are the various things. Next very important thing is children with hemophilia, you should avoid aspirin or other NSAIDs. So we should avoid aspirin and NSAIDs. Okay, so remember that. And also these children should be vaccinated with hepatitis B. Hepatitis B vaccination should. Why should we give hepatitis B vaccination? Why should we give hepatitis B vaccination? Why should we give hepatitis B vaccination in these children? Then say you know this answer. I'm just asking. I want to know how your mind works. So why do we give hepatitis B vaccination? So we give hepatitis B vaccination because they have repeated transfusions. No, since there is repeated transfusions and there is a chance of receiving blood transfusion transfused infections. Okay, so that is, yes, very good, transfusion. So that is why hepatitis B vaccination should be done, and also these patients should be regularly, yeah, these patients should be regularly screened for all these blood transmittable infections. Regularly they have to be screened for. Okay, so what are the complications? So tell me main complication of hemophilia. What are the main complications of hemophilia? One is the transmission of infections, transmission of infection, transfusion of infections following transfusion. Another very important, another very important complication you have to keep in mind. So the other important, very important is these children can go for chronic arthropathy. Okay, chronic arthropathy, especially in the target joint. Target joint. That is because if the recurrent bleed at the same joint can go for chronic arthropathy. So chronic arthropathy is another, to prevent chronic arthropathy is another indication for prophylaxis therapy. Okay, prophylaxis with the replacement factor. Okay, so arthropathy, infections, arthropathy, chronic arthropathy, joint deformity. Yes, so that is the main complication you have to keep. Okay, fine. So next, now we're going to the next topic, that is the von Willebrand disease. Okay, so in the von Willebrand disease, that's the most common inherited bleeding disorder. Okay, so now tell me what is the pathophysiology? What happens here? So you have to know the main thing is here there is the deficiency of the von Willebrand factor. So what does this do? This von Willebrand factor, it will bind the platelets and near the injured endothelium. Okay, it will bind the platelets near the injured endothelium. Bind the platelets near the injured endothelium. Next, what does it do? So there are two functions of the von Willebrand factor. One is it binds the platelets near the injured thing. That is why it can. That's why when it is absent, it can lead to platelet dysfunction. Another very important thing is it is a carrier protein. It is a carrier protein for factor 8. It is a carrier protein for factor 8. Okay, so remember this von Willebrand factor, it binds to the platelets near the injured endothelium, and also it is a carrier protein for factor 8. So when the von Willebrand factor is absent or is a deficient, so that will have two types of presentation. One, it can have a presentation of platelet dysfunction. Another, it can have a presentation of factor 8 deficiency. So this you should remember. Okay, so they have a mixed presentation. So they have even, so yesterday I had told you the differences between a platelet disorder and a coagulation disorder. Platelet disorder is more of a mucosal bleed. So here in von Willebrand disease, you will also present with a mucosal bleed. Yes, it acts like a bridge. Exactly. So this is the endothelium. If this is the endothelium, this is the von Willebrand, and this is the platelet. It will act like a bridge. Very good, Aparna. So that is how the von Willebrand factor acts. So this you should know. Okay, so how do they generally present? So they have a presentation of a platelet dysfunction disorder. So they can have mucosal bleed, so they can have epistaxis. Girls can have severe menorrhagia. Okay, there could be easy bruising. So these are the presentations you have to keep in mind. So next, coming to the classification. So tell me how many types of von Willebrand disease is Types. Tell me how many types are there? How many types are there? Types of von Willebrand. So based on the quantitative and the qualitative problem abnormalities, the von Willebrand disease is divided. So how many types are there? So there are three types. Yes, very good, Sumitra. So there is type 1, type 2 and type 3. So what is type 1? What is type 1? What is type 1? So in type 1, what happens? There is some amount of von Willebrand factor. Okay, so there is some amount of von Willebrand factor. So this is a quantitative defect. Okay, there is some amount of von Willebrand factor is present. Okay, while the type 3 also is a quantitative defect, but here there is absence of the von Willebrand factor. Okay, so type 1 and type 3. So remember the odd numbers, it is the quantitative defect. Okay, so in the type 1 there is a deficiency, there is some amount of von Willebrand factor, but in type 3 there is a severe loss, there is like a complete absence of von Willebrand factor. Okay, so this you have to know. So in type 2 it is the qualitative defect. So the von Willebrand factor itself has an abnormality. It is not the amount it is present or not. Even though it is present, it is an abnormal von Willebrand factor. So the qualitative defect. Okay. So in type 2 there are 4 types. So type 2A, 2B, 2M and 2N. So I am not going to discuss each of this in detail. I will just tell you how does a type 1 present, type 2 present and a type 3 present. Okay, so this you have to know. So there are 3 types. Okay, so they are based on the quantity and the quality. So in type 1 and type 3, there is a quantitative defect. So basically, the amount of the von Willebrand factor is affected. So in type 1, there is little bit of von Willebrand factor which is present, but while in type 3, there is complete absence of von Willebrand factor. So based on this, you will know that type 3 is the more severe one, right? Because there is complete absence of. So this becomes the severe one. While in type 2, there is a qualitative defect. Okay, so there are 4 types. There is 2A, 2B, 2M and 2N. I am not going to discuss each of this in detail. If you remember type 1, type 2, type 3, how they present is more than enough. Okay, so in type 1, what happens? So type 1 is the most common. Type 1 is the most common. Around 60% of the patients present with type 1. So how will they present? They'll have mucosal bleeding. They'll have mucosal bleeding. Okay, so what did I say? There could be epistaxis, there could be menorrhagia, there could be easy breathing, right? Epistaxis, menorrhagia, easy bruising can be there. Okay, so this is how mucosal bleedings happen. Next in type 3, how will they present? So now I've told you there is complete absence, right? So type 3, what will happen? So in type 3, since there is complete absence, they'll have also a presentation of mild hemophilia. So basically they'll have severe platelet symptoms. Along with that, they'll have features of mild hemophilia. Okay, so remember there is mucosal bleeding. Plus they will have joint bleeds. They'll have muscle bleeds. So I told you type 3. So von Willebrand factor is necessary as a carrier protein for factor 8. So now there is no von Willebrand factor only. So what happens? They will present with a mild hemophilia kind of a picture. So there is mucosal bleed. Along with that, they'll have joint bleeds and muscle bleeds. you have to remember one thing. Von Willebrand factor is more of a mucosal bleed, like something like a platelet disorder. But in type 3, along with the presentation of platelet dysfunction, they will also have a hemophilia picture. So this you have to keep. So in type 2, what happens? So type 2, the presentation is similar. There will be mucosal bleed and all that. So basically, now this von Willebrand factor has a it is a multimetric glycoprotein, they say. Okay, it's a multimet. So this multimetric meaning the different dimensions. So that is not maintained. Okay, in type 2. So that is the reason there is abnormality in platelet binding. So because the quality of the von Willebrand factor is not good. So the abnormal platelet binding. Okay, so over here this you have to keep in mind. So all of this will have abnormal binding. So you don't, we will not discuss so much. So there is mucosal bleeding in these patients, similar to platelet disorders. Okay, so you have to know, and also they might have mild hemophilia. You have to know. Next, coming to the lab findings. So in the lab findings, what do you see? So what do you see? There is factor 8 is decreased. There is factor 8 is decreased. PTT is prolonged. So PTT is prolonged, especially if the factor 8 is decreased. So that you should know. Factor 8, if it is decreased, then the PTT is prolonged. Okay. So platelet aggregation test. Platelet aggregation. So yesterday I had told you, instead of the bleeding time, now I have to prefer the platelet aggregation test. So there are various other tests you have to remember in von Willebrand. One is the von Willebrand factor. So von Willebrand factor you have to assess. Okay, that you all know. So there are various other things you have to keep in mind. That is the von Willebrand factor is to the antigen ratio. Okay, then the factor 8 ratio and the multimer distribution. So I have told you the multimerization of the von Willebrand factor is not happening. Basically uh, the complex yeah, ristosetting test, yes, where the complex configuration of the von Willebrand is not maintained. So you have to even check the multimer distribution. So now based on that, so in type 1 how it is going to be, type 2 how it is going to be, and type 3 how it is going to be. So the von Willebrand to the AG ratio will be decreased in type 1. It will be decreased in type 3, decrease in type 2, while it is absent in type 3. Factor 8, it is normal in type 1, it is decreased, severely decreased in type 3, while in type 2 it is normal or it is decreased. Remember that. While coming to the multimer distribution, it is normal in type 1, while in type 3 it is lost. Basically there is no von Willebrand factor itself, so it is lost, and then or it is absent. So we can say it is absent. We can say it's absent. Over here, the multimerization of the von Willebrand factor is not happening. So the multimerization is lost. So this you have to remember. So very important thing is the factor 8. So in factor 8, in all these three, how it is going to be. So in type 1, the factor 8 is normal. In type 2, it could be normal or decreased. But in type 3, it is severely decreased. So this you have to keep in mind. Okay. So now tell me, what is the ristosettin test? Tell me, what is the ristosettin test? So when you add ristosettin to a blood, so basically what happens, there is clotting happening. Okay, so that binds, that causes the von Willebrand factor and the platelets to stick together. So when you add ristocetin and there is not clot happening, then you have to think this could be a von Willebrand disease. Okay, ristocetin test. Okay, so this basically causes the binding of platelet and von Willebrand factor. So when you add ristocetin, that normally there should be a clotting. So when aggregation test, very good. So it clotting, aggregation of the platelets. If that is not happening, then you have to suspect von Willebrand disease. Fine. Now coming to the treatment. So now what will we do? What is the treatment? If it is type 1, so if it is type, so there are three treatments. One is desmopressin. Okay, next is giving von Willebrand factor, and next is antifibrinolytics. Okay, okay, so now tell me desmopressin. Now desmopressin is used where? So now always remember desmopressin is used in a milder form of the disease. So it's used in mild hemophilia, while desmopressin is used in type 1, which is a mild form. So it is used in type 1. Type 1 von Willebrand disease. Okay, so remember desmopressin is in type 1 von Willebrand disease. So over here there is low amounts of vitamin von Willebrand factor. So you remember in type 1 desmopressin is used. Next, giving to the von Willebrand factor. So in case of type 3 you give von Willebrand concentrates. Type 3 you give, type 2 you give. But if the type 1 is severe, then you can go for von Willebrand factors. Okay, so if the type 1 is severe, then you go for von Willebrand factor. Next, coming to antifibrinolytics. So what now comes the tranexamic acid, all that tranexamic acid, aminocaproic acid. Tranexamic acid is used here. So this is used. So tranexamic acid is used especially for mucosal bleeding. So since there is mucosal bleeding here, so that is why tranexamic acid is used. This much, if you remember, is more than enough. Okay, and children have menorrhagia, right? So girls who have menorrhagia, they'll need hormone replacement therapy. Okay, so this is very important. So remember, desmopressin, von Willebrand factor. So von Willebrand factor is used for severe conditions. So type 3 is severe, type 2 can be severe, and type 1, if it is severe, only then you give. Antifibrinolytics is given mostly as tranexamic acid or aminocaproic acid. So basically, this is to manage the mucosal bleeding. Fine. So we have done. Now we'll first discuss today's topic. Okay, so first hemophilia. So hemophilia is the most common severe bleeding disorder. Okay, so there are two types, hemophilia A and hemophilia B. Factor 8 is hemophilia A and factor 9 is hemophilia B. So the clinical manifestation. So one thing you have to know is factor 8 and factor 9 are not transmitted through the placenta. So only around 2% of the newborns can present with intracranial hemorrhage at birth. Okay, but most of the time, when do you see one of the other presentation is when they have a circumcision, there will be severe bleeding. So that is another presentation of hemophilia. When there is de novo mutation, so there could be, see, it is X-linked recessive, yes, but so many times there is de novo mutations. Okay, so the higher there is very high chance of going for de novo mutation. When they go for de novo mutation, the diagnosis is difficult and generally it goes undiagnosed until they present. So generally, when do these children present? So when they try to walk, when they try to, they hit themselves and all that. So there is easy bruising. There could be intramuscular hematoma. So that and the diagnosis can happen. Why is the child bleeding so severely? So another very important presentation in hemophilia is hemarthrosis. So what is it? It is bleeding in the joint. So hemarthrosis especially happens when the child starts to move around. Okay, so this hemarthrosis can be early onset. So whether it is early onset, the child is not able to tell what's happening, the pain and all that. So most of the time when there is early onset hemarthrosis, they come with the swelling of the joint. Okay, they come with the swelling of the joint. But in older children, they're able to tell what they feel. So they have this warm tingling sensation. So that time the older children are able to express, and the diagnosis is done very sooner. So when they come with hemarthrosis in younger child with the swelling, the diagnosis happens. So the first joint to involve hemarthrosis is the ankle joint. So remember, ankle joint is the first joint to involve. So eventually the knee, elbow also gets involved, but the first joint to involve is the ankle joint, and the target joint is, so always the target joint is the one where there is recurrent bleed happening. So recurrent hemarthrosis in the same joint, that joint is called the recurrent, it's called the target joint. So this target joint, the bleed, what happens could be spontaneous. Okay, so the bleed which is happening again and again could be a spontaneous. So there might not need a trauma at all. There could be a spontaneous bleed happening, and in such children are one of the uh, beneficiaries for of prophylaxis. Okay, so generally because there is spontaneous bleed happening, it's very difficult to prevent them from going to spontaneous bleed. These children might require prophylaxis replacement therapy. Okay, that's one. And next, coming to muscle bleed. So one was a hemarthrosis, next is muscle bleed, which is common. So muscle bleed, most of the time they tell there is swelling and there is pain. So parents are able to come up with the complaints. But if it is a bleed in the iliopsoas muscle, so what happens is the bleed is concealed, and the diagnosis becomes late. And sometimes the bleed is so much that the patient might come with a hypovolemic shock. Okay, so especially in these children who have a bleed in the iliopsoas muscle, the um, the leg, the hips are always flexed and internally rotated. Okay, it is flexed and internally rotated. So when you try to extend the hip, it's not possible. There is severe pain. Okay, so that is one way you can have a suspicion that this child might be having a bleed in the psoas region. Okay, and to confirm it, you either need a USG or a CT to confirm the iliopsoas bleed. So that is important. And other thing is, when these children present with a severe life-threatening bleed, like if there is a bleed to the CNS or severe bleed to the various vital organs, that time first thing what you have to do is, before going to an imaging, treat the child, because it is life-saving. Treat the child with the replacement factor and then image. So always remember, treat first and image later. And in mild hemophilia, what happens is, here in mild hemophilia, hemarthrosis or muscle bleed is not very common. So they generally have history of prolonged bleeding following a dental surgery, a dental procedure, or a small surgery. There is prolonged bleeding. So that is a typical history in mild hemophilia. Okay, so this is a picture of hemarthrosis. Okay, so you can see there is a swelling in the knee. So most of the time they don't give an ankle joint. It is the knee joint which will be given, but you should remember that the ankle joint is the first joint to get involved. Okay, so laboratory findings. The first thing you need to know, APTT increased. Then the next, how to confirm it is by getting a specific assay of the factor 8 and factor 9. This will confirm the diagnosis. Next, so genetics and classification. So inheritance is X-linked recessive. There can also be de novo mutations, but while inheritance is X-linked recessive. And based on the activity of the factor, it is divided into mild, moderate, severe. In severe, the factor activity is less than 1%, while in moderate it is 1 to 5%, while the activity in a mild condition is more than 5%. Okay, so to tell these factors, what is the hemostatic level? So hemostatic level is level which prevents from bleeding. So in factor 8, the activity should be at least 30 to 40%. Preferably it should be 100%, but minimum it should be 30 to 40%. And for factor 9, it should be 25 to 30%. So remember that. So coming to the treatment, the dose of factor 8 is important. Okay, so basically, if it is a mild to moderate bleed in hemophilia, the percentage of activity of the factor should be at least 32 to 50%. So you should at least try to attain 35 to 50% of the factor activity. But if it's a life-threatening condition, you have to see that 100% of the factor activity, that much of factor replacement should happen. Okay, so this you should remember. And another very important thing is, out of a factor 8 and factor 9, factor 8 deficiency occurs in 85% of the patients with, yeah, well, factor 9 is around 15%. Okay, and another very important therapy is desmopressin, especially in mild hemophilia. There's endogenous production of factor 8 happening, and desmopressin is intranasally in such patients. So prophylaxis, replacement factor. is given. So basically, whatever the factor is deficient, we give, especially in children who have spontaneous bleed. So especially in hematosis, there is recurrent hematosis which is happening, and it can lead to chronic arthropathy, the joint deformity. So such children is given. Okay, supportive avoidance of aggressive sports. Parents should be counseled, seatbelt should be applied, avoid aspirin and NSIDs. Hepatitis B vaccination is needed in these because there's a chance of getting the infection being transferred to the transfusion. The main complication is chronic arthropathy. So forget about everything. This is the main complication, especially in hemophilia. The child who has recurrent joint bleeds can go for chronic arthropathy. It could be joint deformity. Remember that. Okay, so next coming to von Willebrand disease. So this is the most common inherited bleeding disease. So the pathophysiology, what should you know? First, you should know what is von Willebrand factor. What is the function of von Willebrand factor? So this von Willebrand factor binds to the platelets near the injured endothelium. So it forms as a bridge. So as Aparna said, it forms like a bridge. Okay, and it forms the maintains the hemostasis. Another important function of the von Willebrand factor is it is a carrier protein for factor 8. Okay, so it's a carrier protein. So if the von Willebrand factor is absent, even the factor 8 will be decreased. Okay, so main thing you should know is the main function is the binding to the platelets. So von Willebrand factor, though it is a coagulation disorder, it has, though the presentation of it is more like a platelet disorder. Okay. So now the classification. So there are three types. You should know type 1, type 2 and type 3. While type 1 and type 3 are a quantitative defect. So in type 1, some amount of von Willebrand is absent. There is some activity of von Willebrand factor still. While in type 3, there is complete absence of von Willebrand factor. Okay, so that you should know. And in type 2, there is a qualitative. So basically, the von Willebrand factor itself is abnormal. So there is a defective multimerization of the von Willebrand factor. So the configuration itself is affected. So in type 2, there are 4 types, that is 2A, 2M and 2M. So in now, so in type 1, when coming to the clinical presentation, type 1 is the most common. This accounts 60%. So in type 1, there is like a platelet disorder. So it presents with mucosal bleeding, epistaxis, GI bleed, easy bleeding, menorrhagia. While type 3, they will have also features of mild hemophilia because along with von Willebrand factor, there is the factor 8 as well. So here there is mucosal bleeding. Also there will be joint bleeds, there will be muscle bleeds. Okay. Next in type 2, the platelet binding is abnormal and they'll have a mucosal. Okay. And yes, again, because it's abnormal, even the binding to the factor 8 becomes difficult in these conditions. So laboratory finding, the first thing is if the factor 8 is decreased, then the PTT is also prolonged. Okay, the platelet aggregation test is done. Okay, and the ristocetin, so I have told you it's an antibiotic which when you so generally what does ristocetin do? It binds it aggregates the platelets. Okay, so this is not happening. So the aggregation doesn't happen. So basically once you put ristocetin, there is clotting. So basically it binds the von Willebrand factor with the platelets. So the clot should be formed. So when that is not happening, that means the von Willebrand factor is absent or it's decreased. Okay, so the thing you should know is the main thing in the, one second. So the main thing is this small chart. So the main thing is in this small chart. Forget about the von Willebrand factor, antigen, and all that. I tell you, this is where these two are very important. So, what is the factor 8 level in all the 3 types of von Willebrand disease and the multimer distribution? This is very simple. You don't have to worry at all. So, basically, in type 1, the von Willebrand factor is normal, but the amount is decreased. So, you don't have to worry. So, this is a normal multimerization. While in type 3, there is complete absence of von Willebrand factor. So, the multimerization is not there only. Then in type 2, what happens? The qualitative defect, so the multimerization is lost. So that is what you have to remember. And the factor 8. So factor 8 is normal in type 1, increase in type 2, type 3, and in type 2 it could be normal or decreased. To the multimerization and factor 8 is very, very important. So that, if you remember, is more now. Okay, this vulnerability factor 2 antigen ratio and all, they might not ask. So this was certain test is discussed. Yeah, so the treatment. So treatment, what is there? So desmopressin, vulnerability factor replacement, antifibrinolytics. This is the treatment what we give. So in type 1, since it's a mild form of vulnerability, desmopressin is more than enough. Okay, so this desmopressin is more than enough. But in the severe condition like type 3 and type 2, vulnerability factor is needed. And also in type 1, if it presents as a severe condition, you need vulnerability factor therapy. Okay, so antifibrinolytics like tranexamic acid, aminocaprylic acid is used when there is only manage the mucosal bleeding on the liver disease. So this is it. So I think we've discussed in detail. So this is it. So this is, oh, it was a very good discussion we had. So I think you should you will remember everything well. So do you have any doubts? Do you have any doubts? Yes, very good. So Aparna, yes, type 1 is partial quantitative and type 3 is severe quantitative. Exactly. Exactly. Okay. So tomorrow we'll be discussing ITP, idiopathic thrombocytopenic purpura. Okay, and also some associated neonatal thrombocytopenia, thrombotic thrombocytopenic purpura. So all that we'll be discussing tomorrow. Okay, that is ITP tomorrow. That is 21. Okay. Then I'll be discussing thrombotic disorders in pediatrics. That is on 22nd. Disorders. So this might be a short class. Let's see. 20th. Okay, 22nd. And on 23rd, we'll be having a class on splenomegaly and lymphadenopathy. So all the causes, how does it happen? Yes, 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 exactly. So APTT, if in von Willebrand disease in type 1, since the factor 8 is normal, the APTT, so basically APTT is normal. Yes, only if the factor 8 is decreased, the APTT will be decreased. Okay. No, so from tomorrow, with my classes anymore will be at 2 p.m. because I have some work related things in the morning. So basically, I have to be covering for another colleague of mine. So that is why I have shifted my class to 2 p.m. Okay, so my classes will be at 2 p.m. Splenomegaly lymphadenopathy on 23rd. Next will be a quiz. So all the blood disorders, whatever I have not covered and everything, all this might go for 1.5 hours to 2 hours. Okay, so this is the quiz. After this, I will take a random pediatric quiz. Random pediatric quiz. I'll try to cover all the topics, all the classes as much as possible. So it'll be a random pediatric quiz. Then this also around 1.5 hours to 2 hours. Okay, as many questions as possible we'll discuss. If you'll get tired, we'll stop. Okay, so it will be a random pediatric quiz. Then in this I will not be discussing endocrine. Then another class will be endocrine quiz. Endocrine quiz. Okay, so now in the Unacademy class, special class, okay, special class, we will have a rheumatology quiz. I don't know, either rheumatology will be already, I have already asked quizzes. So there'll be only one splenomegaly and lymphadenopathy is done. There's only going to be quiz. Okay. So in the special class, there could be rheumatology plus some allergy quiz, and then this random pediatric quiz, whatever is pending, whatever questions we don't do there, this random pediatric quiz will happen in the special class also. Okay, so I will try to finish all the topics of pediatrics, so whichever is important, so we'll do. So, see, we'll do only question and answer. If you'll have any doubt, you'll ask in between. Otherwise, we'll just go on doing question and answer. So if you'll have any doubts, you'll ask. Okay, so that is how we'll do, because this is I will there will be like 100 questions. I think I don't know how many questions I'll do. How much ever I can, I'll go on adding. So that is how it is going to be. So once ITP, thrombotic disorders, splenomegaly, and lymphadenopathy is done, then only the quiz. Okay, so blood disorder quiz, endocrine quiz, and one will be a random pediatric quiz. It can have any topic, so just have a fast brush up of all the questions, so that will help you during your during the quiz session. Okay, yeah, so thank you Aparna and Sumitra. All right, and another very important thing, four things I always say: study daily, do not have a break, avoid social media, wake up early, and sleep early and wake up early. And fourthly, if you have a study partner, discuss with them. So this is very, very, very important. I always tell that only then, and you have to be disciplined. Have to be disciplined when you're studying for your NEET PG. Okay, I know it's 1 year of 1 year is going to be very frustrating, but no, you have to, and have friends, talk with them. It will help you to feel better. And if you're subscribing to the subscription, use my code Shilpa10 to get a 10% discount. Okay, so see you. Good luck. Stay safe. Stay healthy. Okay, bye.